Hello and welcome. Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. I'm Dr. Rebecca Jane Collins. In this explainer, we're going to be taking a really deep dive into the complex and I think truly fascinating pharmacology of anesthetic drugs as they apply specifically to cardiovascular anesthesia. We'll be using some key slides from the core literature to break down this crucial topic.
So our roadmap for this session is pretty straightforward. We're going to start with the volatile agents, looking first at their immediate, acute effects, and then at their more delayed, protective effects. From there, we'll move on to a comparative look at the hemodynamics of our various IV induction agents. Then we'll explore the really interesting cardioprotective role of opioids, and we'll wrap things up by tackling the unique and often tricky pharmacokinetic challenges we face when a patient is on cardiopulmonary bypass.
All right, let's get straight into it, shall we? Part 1. Here, we're focusing on the immediate, dose-dependent effects our volatile agents have on the heart and the vasculature. Getting a solid grip on these acute changes is absolutely fundamental to our day-to-day safe practice in the cardiac theaters.
Okay, the first and most crucial point, the one thing to always keep in mind is this. Every single one of our volatile agents causes a dose-dependent drop in systemic blood pressure. There are no exceptions to this rule. But, and this is a really big but, the story isn't nearly that simple. The real art of cardiac anesthesia lies in understanding how each individual agent does this, because the underlying mechanism is completely different and has profound clinical implications for our patients.
And what's really interesting here is how our agents split quite neatly into two distinct camps. You have the older agents on one side, halothane and enflurane. They lower blood pressure by directly depressing the heart muscle itself, what we call a negative inotropic effect. Now, contrast that with our more modern agents, isoflurane, desflurane, and sevoflurane. They achieve that same drop in pressure, but they do it mainly by relaxing the blood vessels, causing a fall in systemic vascular resistance. And the crucial part is that they are relatively sparing of cardiac output. This is a critical distinction, isn't it? Especially when you're anesthetizing a patient who already has pre-existing ventricular dysfunction.
So, let's get a bit more granular. How exactly does this happen at a cellular level? Well, it's really a multi-pronged attack on calcium handling. The volatile agents directly modulate the L-type calcium channels, which reduces the influx of calcium into the cell. At the same time, they decrease the release of the calcium that's already stored inside the sarcoplasmic reticulum. And as a final blow, they actually reduce the sensitivity of the contractile proteins themselves to the calcium that is available. So it's this combination of less calcium and a weaker response to it that collectively reduces the force of myocardial contraction.
And of course, we can't forget about nitrous oxide, which is a bit of an outlier in this group. It has this really fascinating paradoxical effect. On the one hand, it does exert a direct, mild depression on the myocardium. But on the other hand, it simultaneously stimulates the sympathetic nervous system. So the net cardiovascular effect you see is really a tug of war between these two opposing forces. And the winner of that tug of war depends entirely on the patient's underlying sympathetic tone. In a patient with a really high sympathetic drive, like someone in septic shock, those depressant effects might suddenly be unmasked. So we've covered systole, right, the contraction phase. We've talked about that pretty thoroughly. But the heart's ability to relax and fill, the diastolic phase, is just as, if not more important, particularly in our cardiac patient population. We're often dealing with patients who have conditions like long-standing hypertension or aortic stenosis, and they may have significant pre-existing diastolic heart failure. So what do our anesthetic agents do here?
Well, as this table shows, diastolic heart failure is a really multifactorial problem. It can stem from impaired myocardial relaxation, reduced compliance, or even external factors like constrictive pericarditis. It's a very complex state, and what the literature shows us very clearly is that volatile agents prolong the isovolumic relaxation phase in a dose-dependent manner. Now, what that means for us clinically is that we must be particularly cautious when we're anesthetizing a patient with a stiff, non-compliant ventricle that desperately needs adequate time to fill.
However, as is so often the case in pharmacology, it's rarely straightforward. There's a really interesting paradoxical finding that in the specific setting of reperfusion injury, where the myocyte is often overloaded with calcium, sevoflurane has actually been shown to improve diastolic function. It's thought that it does this by modulating those very same calcium channels we were just discussing. It's a fascinating nuance. Now let's shift gears a little and talk about cardiac electrophysiology. A critical point for us in practice is that volatile agents can lower the threshold for catecholamine-induced arrhythmias. But the degree of the sensitization varies significantly between agents. As you can see, halothane is the classic offender here. It makes the myocardium highly sensitive to adrenaline. This is why it's fallen out of favor.
At the other end of the spectrum, you have isoflurane and desflurane, which have the lowest potential for this very dangerous interaction.
And if we look at the molecular level, we see this complex interplay with various cardiac ion channels. The inhibition of L-type calcium currents, well, that explains the reduced contractility we've already discussed. But look at the second row. The enhancement of ATP-dependent potassium currents by isoflurane and sevoflurane. This is absolutely key. It's a central mechanism in myocardial preconditioning, a topic we're going to explore in much more detail in our next section. And finally, the inhibition of fast sodium currents explains the potential for slowed conduction through the heart.
Let's just touch on a quick piece of anesthetic history, because it's quite important. The coronary steal debate surrounding isoflurane was a massive topic back in the 80s. The theory was that because isoflurane dilated healthy coronary arterioles, it could divert or steal blood flow away from already stenosed vessels which were maximally dilated just to get by. However, subsequent, more rigorous studies came along that meticulously controlled for confounding variables like blood pressure and heart rate, and these studies demonstrated that this effect, while theoretically possible, was not clinically significant. The consensus today is quite clear. With careful hemodynamic management, isoflurane is safe to use in patients with coronary artery disease.
So the vascular effects of these agents are really widespread. They all blunt the baroreceptor reflex, which is our body's primary defense against hypotension. But a point of immense practical importance, especially in thoracic anesthesia, is that the newer agents, sevoflurane and dysflurane, are notable for preserving the hypoxic pulmonary vasoconstriction response, or HPV. This response is absolutely vital for matching ventilation and perfusion when we're in a one-lung ventilation setting, so this is a really desirable property.
Okay, so we've covered the immediate effects quite thoroughly. Now let's explore one of the most exciting areas of anesthetic pharmacology, the delayed protective effects of volatile agents on the heart. This is the whole concept of anesthetic preconditioning. It's a game changer.
Now, to really understand preconditioning, we need to place it in the context of the spectrum of reversible myocardial ischemia. So we have stunning, which is that post-ischemic dysfunction where blood flow is restored but function takes time to recover. Then there's hibernation, which is a chronic state of dysfunction due to chronically low blood flow. And then there's preconditioning, this remarkable phenomenon where a brief, non-lethal period of ischemia actually protects the heart against a subsequent, much more prolonged and dangerous ischemic insult.
And this is just so important because, as this diagram shows, a myocardial infarction isn't an all-or-nothing instantaneous event. It begins in the vulnerable subendocardium and it progresses outwards like a wave front of cell death. The entire goal of preconditioning, whether it's ischemic or anesthetic, is to slow or even halt this advancing wave of necrosis, salvaging as much viable myocardium as we possibly can, and ultimately reducing the final infarct size. It's a race against time.
And this leads us directly to anesthetic preconditioning, or APC. And this, for me, is the amazing part. We can achieve a state of potent cardioprotection, very similar to that induced by brief ischemia, simply by exposing the heart to a volatile anesthetic agent. And crucially, this protection is completely independent of changes in myocardial oxygen supply and demand. We are actively using our drugs not just for the purpose of anesthesia, but as a powerful tool for organ protection.
So how on earth does it work? Well, the truth is, the signaling cascade is incredibly complex, involving protein kinases and nitric oxide and many other things. But at its core, the activation of mitochondrial ATP-sensitive potassium channels, or KATP channels, is considered to be a critical final step in the protective pathway. And this isn't just some laboratory curiosity. The clinical evidence from numerous large meta-analyses is really quite compelling, associating volatile-based anesthesia with a reduction in post-operative myocardial infarctions, a decreased need for inotropes post-op, and even shorter ICU stays for our patients.
Okay, brilliant. Let's switch gears completely now. We're moving away from our inhalational agents and turning our focus to our intravenous induction agents. Now, while all of these drugs produce hypnosis, their cardiovascular profiles could not be more different. And choosing the right one for the right patient is truly a cornerstone of our practice.
So the great unifying principle for most of our IV agents, with one very notable exception that we'll come to, is sympatholysis. They all, to some extent, blunt the sympathetic nervous system. And this is precisely why they must be used with extreme caution in patients who are critically dependent on a high sympathetic tone just to maintain their cardiovascular stability.
I'm talking about patients in shock, those with severe heart failure, or those with cardiac tamponade. In these patients, pulling away that sympathetic drive can be catastrophic.
This table provides a fantastic at-a-glance comparison, and the differences are really striking, aren't they? Just look at the third row for etomidate. You see almost straight arrows across the board, indicating its remarkable hemodynamic stability. Now contrast that with propofol just below it, where you see these big double-down arrows for mean arterial pressure and systemic vascular resistance, indicating profound vasodilation. And then at the very bottom, you have ketamine, which is in a class of its own. It has a completely opposite sympathomimetic profile, with everything going up.
So let's just quickly hit the main clinical takeaways for each. Thiopental causes significant venodilation, which makes it a really poor choice in a hypovolemic patient. Etomidate, as we said, is our most stable agent, but you must always remember the transient adrenal suppression. Ketamine's sympathomimetic properties make it the agent of choice for cardiac tamponade, but you have to be aware of its underlying direct depressant effect, which can be unmasked in catecholamine-depleted patients. And finally, propofol, our daily workhorse, is a potent arterial and venous vasodilator and a myocardial depressant, which explains that significant drop in blood pressure we so often see on induction.
And beyond the main induction agents, there are two others with unique properties worth mentioning. Dexmedepidine, an alpha-2 agonist, is an incredibly useful adjunct for stabilizing hemodynamics and reducing our anesthetic requirements, though we have to be mindful of causing bradycardia at higher doses. And interestingly, to come back to propofol, it also possesses some antioxidant effects that may offer a degree of protection against the oxidative stress seen during ischemia-reperfusion events.
We're going to turn our attention now to opioids. And in cardiac anesthesia, these drugs are absolutely fundamental. We use them in very high doses, not just for their profound analgesic effects, but for their incredible ability to ensure hemodynamic stability in the face of intense surgical stimulus. And as we'll see, they also have their own fascinating cardioprotective properties.
So, the pharmacology of opioids really starts with understanding their receptors, mu, kappa, and delta. Our most commonly used clinical drugs like fentanyl and sufentanil are primarily mu receptor agonists. Understanding this is absolutely key to predicting their specific effects, both the desirable ones and the side effects. And of course, all of these can be reversed by antagonists like naloxone.
Now, here's something that is truly fascinating. The heart doesn't just respond to the opioids that we administer, it actually has its own intrinsic opioid system. The myocardial cells themselves can synthesize, store, and release their own opioid peptides, like enkephalins. This internal system is activated during times of stress, like ischemia, and it appears to be a built-in, natural mechanism for cardioprotection. It's quite amazing, really. So, the crucial point for us in the operating theater is this. High-dose opioids provide such a uniquely stable anesthetic for cardiac surgery because of their powerful ability to suppress the central sympathetic response to the intense stimulus of, say, a sternotomy. By blocking this massive stress response right at its source in the central nervous system, we can prevent those wild swings in heart rate and blood pressure that would otherwise occur.
And this statement is so powerful because it perfectly bridges our previous discussion on preconditioning with our current topic of opioids. Just like the volatile anesthetics, it turns out that opioids can also trigger a preconditioned protected state in the myocardium, and a growing body of research is pointing very specifically to the delta opioid receptor as being a key player in initiating this protective cascade.
And here's the proof. Seminal laboratory studies have shown that the protective effect of ischemic preconditioning can be completely abolished by giving the opioid antagonist naloxone. This is a crucial finding because it proves that the release of endogenous opioids is an essential, non-negotiable step in that protective pathway. And this is translated from the bench to the bedside, with clinical studies showing that agents like remifentanil can reduce myocardial injury biomarkers like troponins in patients undergoing cardiac surgery.
All right, for our final section, we're going to address the profoundly challenging and unique physiological environment of cardiopulmonary bypass. The moment a patient goes on bypass, we are dramatically altering their normal physiology, and this has massive implications for how our anesthetic drugs behave in the body. In other words, their pharmacokinetics.
You know, cardiopulmonary bypass is anything but a steady state. Virtually every single pharmacokinetic parameter is altered. The large priming volume in the circuit causes profound hemodilution, which increases the volume of distribution and instantly lowers drug concentrations. The routine use of hypothermia slows down drug metabolism. The non-pulsatile flow means blood flow to clearing organs like the liver and kidneys is reduced. And even the plastic tubing of the circuit itself can act like a sponge, sequestering lipid-soluble drugs and taking them out of circulation. So let's see how this actually plays out with our commonly used opioids. There's a really clear difference based on their chemical properties. Fentanyl, because it's highly lipophilic, is significantly sequestered by the bypass circuit. We're talking up to 70% of the drug. This causes a sharp, often dramatic, drop in plasma levels the moment bypass is initiated, and it's something we absolutely must anticipate and treat. Sufentanil is less affected, while alfentanil, which is the least lipophilic of the three, has by far the most predictable and stable pharmacokinetic profile on bypass.
And this general pattern of reduced clearance and a prolonged duration of effect holds true for many of our other commonly used drugs as well. For benzodiazepines like midazolam, the combination of an increased volume of distribution and decreased clearance can significantly prolong their half-life, leading to delayed waking. For propofol, the consensus is that its clearance is also reduced. And for our steroidal muscle relaxants like rocuronium and vecuronium, the hypothermia of bypass significantly inhibits their hepatic metabolism, which can really prolong their duration of action.
And all of this brings us really to our concluding thought. There is no such thing as a single best cardiac anesthetic. The true art and science of what we do lies in taking all of this detailed pharmacological knowledge, the acute hemodynamic effects, the potential for powerful cardioprotection, the altered behavior of drugs on bypass, and integrating it all to design a bespoke anesthetic cocktail that is perfectly optimized for the unique physiology of each individual patient and the specific demands of their surgery. Thank you very much for your attention.